Hey everyone, welcome back. Good to see you here. Let me start with a case that still gives me chills. A 32-year-old woman walks into triage, moving slowly, holding her head so tightly you can see the tension in her fingers. No trauma, no migraine history, nothing. She looks at me and whispers, "Doctor, this is the worst headache of my life." In moments like this, your brain wants to jump straight to diagnoses. But experience teaches you that surviving these situations depends entirely on having a clean, disciplined structure. So today, Matthew and I are taking you through the exact approach we use, step by step, the one that catches subtle dangers, avoids the classic mistakes, and keeps your patients safe.
Happy to be here. I'm Matthew, one of the residents, and I'll walk with you through each part. So, right at the beginning we ask the simplest but most important question: is the patient unstable? Before thinking about meningitis or migraines, you look for ABCD issues, seizures, altered consciousness, or shock. One of the most common mistakes new doctors make is getting too focused on the headache itself and forgetting that airway and breathing beat everything else. If they're unstable, you resuscitate first, you get an immediate non-contrast CT head, maybe CTA if needed, and you call neurology or neurosurgery right away. If the patient is stable, then we move forward with confidence.
Now we enter the phase where we search for red flags, and this is where things often go wrong in real life. You go through systemic symptoms like fever, weight loss, cancer, HIV. You consider neurologic deficits, altered mental status, sudden thunderclap onset, older age above 50, papilledema, pregnancy or postpartum states, or headaches that change with position. And then come the subtle ones that junior residents tend to miss: immunosuppression. Any form of trauma, even if it seemed minor. A new pattern headache, even if it vaguely resembles their previous migraines. Exertional triggers like sex or heavy lifting. And carbon monoxide exposure, which is one of the easiest killers to overlook. If any of these appear, you shift into the high-risk path immediately. If none appear, you hold that thought because it matters later.
So now we're in the high-risk path, where missing something can mean missing an aneurysm, a bleed, an infection, or a vascular catastrophe. First, if the headache is thunderclap, you must rule out subarachnoid hemorrhage. A normal neurologic exam does not exclude SAH. That's a major pitfall. You start with a non-contrast court. If it's positive, you call neurosurgery and get CT angiography. If it's negative and within 6 hours of onset, you can be reasonably reassured. If it's negative but more than 6 hours have passed, you must do a lumbar puncture for xanthochromia. Another frequent mistake is skipping the LP because the CT is clean, but the story still screams SAH. You never ignore the story.
If the patient has focal deficits or altered mental status, you get imaging again: CT, CTA, or MRI depending on what's available. One of the biggest traps is assuming a new neurologic deficit is just a migraine aura. Unless the patient has years of identical events, a new deficit is never just aura. You treat it as a possible bleed, stroke, or mass until you prove otherwise. When fever, neck stiffness, immunosuppression, or concerning infectious signs appear, you think meningitis or encephalitis. If there are focal deficits or altered awareness, you do a CT before LP. But you never delay antibiotics or acyclovir while waiting. Early treatment saves lives, not perfect timing of imaging. If the headache appears with blood pressures above 180/120, you start thinking hypertensive emergency or PRES, and another common mistake is dropping the blood pressure too fast, which can make things catastrophically worse. Gradual control is the rule unless you're dealing with eclampsia.
For patients above 50 with a new headache, always think about temporal arteritis. And here's the trap: ESR and CRP can be normal early on, so a normal result doesn't safely exclude it. When suspicion is real, you start steroids immediately to protect vision and biopsy later. In pregnancy or postpartum, the threshold for calling a headache high risk is much lower. Cerebral venous thrombosis is massively underdiagnosed in this group. When you have headache with focal deficits or seizures postpartum, assume CVT until proven otherwise and get MRI, MRV, or CT venography. And of course, trauma, Even mild trauma in elderly or anticoagulated patients can hide subdurals. You always CT them.
Now when all those red flags are absent and we've ruled out the dangerous things, we enter the low-risk path. Here's where we handle the common but still important stuff. Migraine is typically recurrent, stereotyped, with nausea and photophobia. But here's a vital rule. A first-ever severe headache is never called migraine in the emergency setting. Treatment is straightforward. NSAIDs, triptans, metoclopramide, hydration, and avoid opioids. Tension headaches feel like a band of pressure and usually come from stress, dehydration, or muscle tension. You'll see this a lot in residents after night shifts. True sinus headaches are actually rare. People overdiagnose them constantly. To call it sinusitis, you need fever, facial tenderness, and purulent discharge together. Otherwise, it's probably a migraine pretending to be sinus pressure. And then there's medication overuse headache, the hidden epidemic. Daily analgesic use rewires the pain system and creates a chronic headache loop. The treatment is withdrawal and often starting proper migraine prophylaxis.
And that brings us full circle. When you follow this structure every time, stability check, red flags, high-risk life-threatening causes, and then the low-risk common diagnoses, you avoid the classic traps and you protect your patient's brain, vision, and life. It's the cleanest and safest way to approach acute headache in the real world.
Thanks for hanging out with us today. If this helped sharpen your clinical thinking, make sure you hit that subscribe button, drop a like, and share it with someone who needs a solid, reliable framework. And before you go, check out the other videos on the channel. There's a lot there that'll boost your skills fast. Take care, and I'll see you in the next one.